have a short introductory talk on stabilization and resourcing. As you know, since the aim of objectives of this talk is to explore the importance of patient stability during EMDR therapy, to examine methods to ensure patient stability, and why this is important, and to explore the different methods used to stabilize patients and give them resources to do so. As you know, since Francine Shapiro's famous walk in the park, EMDR became the sort of therapy par excellence for trauma all over the world, accepted in most national guidelines, including the NICE National Institute of Clinical Excellence since 2005 here in this country. WHO approved it as the most effective therapy with CBT, though they said they also noted that patients needed less sessions and dropout is less. So really, I'm going to talk about EMDR as a trauma therapy and why we need the resourcing when we use it as a trauma therapy. This is my resource, is my meeting with Francine Shapiro in 2014. I gave her a copy of my book on EMDR in Arabic that she liked it, and that is my sort of claim of fame. And my resource that I use always. As Shapiro herself suggested in her book 2001, it is very important to ensure patient stability in any trauma therapy because of the risk to self and others. As you know, suicidal thoughts are very common, and also aggression to others is part of the symptomatology and problems presented by patients with PTSD. Environmental safety is very important because sometimes the cause of the trauma continues to be there, particularly in cases like war situation, domestic violence. So it is very important to ensure that environmental safety and not only feeling safe, because a lot of, but actually being safe. This is very important because, as you know, feeling safe, a lot of people, this part of the symptomatology of PTSD is not to feel safe. But it is important to ensure that patient is safe actually before we liaising with the police, with social services, whatever other agencies to ensure patient safety before we start treatment. Social support is very important because patients go from the session to the family and friends, and they need their support to continue because, as you know, EMDR doesn't stop at the session. People continue to process through the week till they see you next. And in my experience, the first 36 hours after the session can be quite difficult, particularly after a difficult session. So that's very important to note. Physical health is important because, again, trauma itself might have caused, particularly accident, other problem, war, violence, might have caused physical problems associated with that. And a lot of EMDR therapists, when I do supervision, ask me, if this patient have heart attack, should I do EMDR on them? And my answer is always, check with the GP, always. Check with the GP, get more information about what is happening with the heart, and before we can decide about this. Neurological impairment, again, probably in car accidents, you have neurological impairments and epilepsy as a problem, and then it is very important to ensure the stability and liaising again with the neurologist or the GP in that sense. Again, a very common problem with PTSD is drug and alcohol problems, and although we have protocols for these problems, it is essential that patients go, or clients go through the drug and alcohol programs before they do the EMDR to stabilize them first. Legal issues, you know, compensation, always a problem. I saw a patient, a soldier who was suing the Ministry of Defense for not sort of looking after his mental health. And actually, I was really starting EMDR, my clinic, veterans and trauma clinic, and my supervisor told me, don't touch this case until the court is over, because this complicates the issue, the issues of the treatment issues that are presented. Timing is important, the presence of life events and grief and mourning is important in that sense, because we need to give people the space to have the natural process of grief. And as you know, even the NICE guidelines suggest that we have at least a month of watchful waiting before any traumatic incident, because we need to leave the natural healing process to go on before we intervene in any way or form. Dissociative disorders that are very common in particularly complex PTSD and complex trauma is something that can affect our ability to conduct the therapy, because patients are, although physically they are in the session, they are somewhere else because of the splitting and the way they present, as one of the patients described it, being in a glass box, so as if they are not there. Actually, physically they are there, but they don't respond to the therapy or whatever it is. And severe anxiety, again, is the bigger problem in therapy. Impulse control problem that is associated at times with complex trauma, but also can associate with severe anxiety. So really, the main methods of stabilization we use is relaxation techniques, and although I put it here separately, actually should be one of the relaxation techniques, which is the diaphragmatic breathing. I just will have a minute to talk about this, because this is very important, because as you know, in trauma, the main system in the body that overwork is what's called the sympathetic system, which causes people to fight or fight-flight reaction. And there is the opposite system, which is the parasympathetic system. And if you want to ask me later about it, I'm happy to explain the two systems. Is the system that is the opposite and it causes the relaxation. And if you make sure you diaphragmatically breathe, this helps to sort of trigger the parasympathetic system and help people to relax. And it is very important. I thought maybe we could do half a minute exercise on this. So if you can put your hand on your belly and have a deep breath, see if you can sense where you're breathing. A lot of us do not breathe from our bellies, we breathe from our chest only, and that is a problem. While if you make sure you breathe from the belly, and one way of doing that, exercise that I learned from Eric Gentry in his book, Trauma Tools for Recovery. Unfortunately, I didn't put it in the references. I can give you the reference later, is to put your hands behind your neck, okay? And so pull your hands backward and try not to breathe. You are forced to belly breathe, to diaphragmatically breathe. And this is very helpful exercise I have tried with patients, and it helped them to relax. Very important tool, particularly as anxiety is a major, because people continue with the fight-flight situation, and it is important to stimulate the parasympathetic system to help people relax. We have other techniques like the light stream technique, particularly with people who come with pains and aches. And this is, simply and shortly, is the client imagining light of the color they feel more relaxing to them, entering their body from above, filling their whole body to help them to relax. Then the client tries to focus and wash the place where the pain or tension is. And that can be quite helpful in localized patients with localized problems, in my experience. And of course, the most important technique, and I'm not going to go in details into that we have and reserve is the safe, calm, peaceful place that Jackie explained before. I'll just go through it very quickly. Medication can be a good, really it is a sort of double edge, because it can be quite helpful, particularly when patients are depressed, very psychotic. But on the other hand, sedating antidepressant and also sedating anxiolytics like the Valium group, the benzodiazepine, can interfere with the processing. And that's why it is very important to make sure that patients have either reduced dose or do not have them, if possible, of course, in liaison with the psychiatrist and the GP, to ensure that we have a more effective processing. I mean, although we have antipsychotic drugs that are very powerful, like clozapine, and I did use EMDR on patient on clozapine. It worked, but it slows the process. So it is very important to be mindful of that. If people do not like to take medication, people depressed, there are other resources like exercises, physical exercises, aerobics, going to the gym, swimming. All these things can help the mood, help people to relax. So that's another resource that could be used. In patients with, or clients with dissociation, grounding techniques, and there are sort of a spectrum of grounding technique, probably at this level. I don't want to go in details, but from sort of throwing a ball or a pillow to, or a piece of paper to the patient to pick, to make them sort of come back here, to the here and now, to the technique that's called 3-2-1, in which we ask the patient to hear two things, see two things, and touch and describe the gesture of two things. And also we have a more complex one, which I'm not going to go into details, but Jim Knight's book, EMDR Toolbox, described very well, and I've been using it really successfully, is the constant installation of positive orientation and safety. There are also containing exercises in which the patient imagine a box or a barrel or something to put the difficult emotions in. Helpful exercise in closing a session, or when people have difficult emotions about a subject that is bothering them and interfering with the therapy itself. And also, most importantly, coordination, as we described previously, with other care organizations, from GP to psychiatrist to the psychiatric community team, because you might need them if the patient is suicidal and need admission, you might need them if they have physical complication. So keeping in liaison with these agencies, social services, police, in case of real risk to self or others, is very important. Safe place, as I say, I'm not going to go into details because it has been described and exercised by Jackie very well, but it is really identifying a place, real or imagined, that the patient feels safe, calm, have they been to, or they have seen or imagined, and then they say asking the patient to close their eyes. But in my experience, some patients cannot close their eyes, particularly people with severe trauma, sexual abuse, but we can give them the option, if they can do it, to close their eyes. And then to bring up the image, try to enhance the image by describing the sounds, temperature, smells, body sensation in that particular place. And then instructing the client to hold this image in the mind and do 4 to 6 slow eye movements to try to install this safe place. Then after that, we try to instruct them to find the cue word and try to then use it themselves in a mildly troubling situation to see if they could use the safe place triggered by the cue word to help them reduce the disturbance caused by the mild disturbing situation. Resource development and installation, I'm going to talk a little bit about this because I know that it has been used as a stand-alone therapy, I've been told by, so maybe I also will hear from you about it because it has been, I gather, the BECOME project has been used as a stand-alone trial technology, and it is developed by Leeds, and it is described fully in his book, 2009. And it is a situation-specific resource. We need to identify, like for example, in domestic violence, clearly what the patient needs to do is leave the home, for example. We ask the patient, what would help you to do this action, for example. And then we try to identify either a mastery situation, i.e. achievement that the person themselves have done, skills, achievement in terms of self-care, or being able to self-soothe in the past that they can use, or relations in terms of people who looked after them, or people who are a role model for them in the family or family circle, or friends. But also it can be symbols derived from culture, religion, history. And people can use figures which are historical, but they can be helpful in giving people either a sense of protection, or a sense of wisdom, or a sense of nurturing, according to the personality and character of this, or even sometimes imaginary creatures, or imaginary animals, or imaginary things that can help in the process. Then we need to access these situations, and like we did with the safe place, try to describe the situation. For example, if it is a person, asking the patient to give more details about these people in the more supporting situation, or more wiser situation, or nurturing situation. And then we try to repeat all write all this, and try to help strengthen, install this by using 6 to 12 eye movements, lower eye movement, and repeat that as we need to sort of install it. And that could be a very helpful resource that people could use whenever they are in distress, feeling anxious, depressed, panicky, and it is very helpful, as actually Leeds described in his book, that it was even helpful in physical problems, people with severe physical, debilitating physical problems. He found that this technique is helpful. I'm very interested to hear more actually about your experience using it in the trial. More recently, I just want to touch on this, particularly Van der Kolk. He suggested that, particularly in complex PTSD, EMDR is very effective, but not enough on its own. We need to use other resources, and he suggested, and he's using in trials successfully, things like yoga, neurofeedback, which is different from biofeedback, which we all know. Neurofeedback is a more sophisticated technique of people changing their own brainwave on EEG. I mean, I really don't know a lot about it, but from what I read in Van der Kolk books, but I would love to train on that, because it seems to be quite effective from the trials they did. Theater seemed to be very effective, particularly with soldiers with PTSD, and particularly Shakespearean theater. And he also did a trial on that and found it quite effective in terms of the roles they take, in terms of the movements and things they do in the theater helps a lot. And lastly, I have to use my own literature, as people always do. A paper that I wrote with my EMDR supervisor, Jamie Hacker, about Sufi, which has been used in the Muslim world for hundreds of years to treat trauma and deal with them. There's a lot of anecdotes about this. To use it as a resource with EMDR, we describe this, and we are hopeful with Professor Madoud being interested in this, we might do a trial on this, which would be great. And I would like to ask you about later when we meet for our half an hour on this. So in conclusion, ensuring the stability of and resourcing of clients is a very important component of preparing clients for EMDR and to ensure that they are able to withstand, cope with the therapy. Because as I said, therapy doesn't stand in the session. But also, of course, we can use this in the, and I shouldn't miss this, because when you end the session, you might use some of these skills, particularly in a safe place, to try to calm people before they go home. But they can also use these skills at home. And as I said, the first 36 hours is usually, in my experience, can be quite difficult, and these techniques can be very helpful. Different methods of stabilization were discussed. Safe place and resource development were discussed more sort of fully, but I think I just touched on the safe place because it has been described in the short time. This is a Chinese saying, tension is who you think you should be. Relaxation is who you are. And I think in PTSD, and patients or clients with PTSD, they think the tension is the state, the normal state of them, but actually relaxation is the solution to their problem, because then they can benefit from the EMDR, from the therapy, and they can resume their life fully. I think that is, yeah, this is the reference. So thank you very much, and I'm happy to. It's nice to have a name with A, because you all
Questions? Yeah.
How many friends about applying stabilization and resources for the patient who has severe trauma and complex trauma?
Complex trauma, yes. I think it is very helpful. It is a very important tool to help them, but as Van der Kolk said, it's not enough. Okay, you have to have multitude of psychological and somatic and other therapies, including the one I described earlier, to treat complex trauma. But of course, it is a very helpful tool, of course, and it can help reduce the symptoms. But it won't resolve the trauma itself, because it is by nature complex trauma.
What is this word? Sufi?
Sufi.
Then what is the next word?
Dhikr is remembrance.
Zikr.
Yeah.
Okay.
Remember, I think some people write it with Z and some people write it with DH. So,
what is it about?
well, using the recitation and the Quranic verses and things like that, because we feel that what is happening in the Sufi dhikr, especially with the head movement and the body movement, is a bilateral stimulation. And used with the symbols and sort of spiritual contents of the zikr itself are the resources that can be used also in a Muslim patient, of course, in a Muslim country. And also it will make people more acceptable in the Muslim world, and particularly in the Middle East, because as you know, because of the situation in the Middle East, people are paranoid about anything Western. And it will sell EMDR in a better way if you have a cultural component, compatible cultural component in it.
Is it about Rumi and Shams Tabriz, or is it about the Muslim? Is it about Rumi and Shams Tabriz, or is it about...
Well, as you know, there are many sort of tariqas for Sufism, and Rumi is one tariqa, which is very common in Turkey, as you know, with the whirling dervishes, but also there are the other sort of wide, like the Qadiri, Naqshbandi, and other many. Don't know how many do you have? I think 12 or many tariqas of Sufis.
If you're concentrating just on the Muslims, it would cause sectarianism, because everybody has different...
Well, you have to cater your therapy to patients' culture cultural needs, and I think spiritual needs are one of the cultural needs that need to be addressed.
Maybe nine first, and then.
Oh, sorry. Go ahead.
It's okay.
Yeah, you rest 2 times already.
Yeah, thank you. I was introduced with the EMDR, and I think it's a new thing for me. Then you introduced with the stabilization, so I'm wondering about the relationship between stabilization and EMDR.
Yes.
Whether stabilization is EMDR or it's different things, because you mentioned relaxation and everything. I knew about it before, like CBT, because I'm a CBT background. I knew about the relaxation, imagery, and everything.
Yeah.
So this is 2 different parts, or this is connected to one another, or I don't know. And not really.
Well, they are connected in a, I mean, stabilization, as Shapiro said in her book, is a requisite for all trauma therapy. Any trauma therapy you use, you have to ensure stabilization and use stabilization and resources to help the stabilization. But of course, there are resources that are specific to the EMDR. There are resources that are derived from other therapies. And the great thing about EMDR is that it mixes a lot of other set of psychotherapeutic disciplines and can borrow from others, but still within the model of EMDR itself, using the adaptive information processing. So if it fits with the theory, then even if it is something used in other therapy, we can, of course, use it. Because as I said, particularly with EMDR, the processing continues through the week, between sessions. It's not only, doesn't happen through the session only. And I said that, and I read also that the first 36 hours, and my experience also confirmed that, is very difficult after, and that's why we need tools. Some of it, like the Safe Place, is really an EMDR tool, but some of the techniques I described are used by other, I mean, the LEADS technique, the RDI, is again an EMDR technique that was developed. But some of the breathing techniques are used by other but there's no harm in using it as long as it fits within the EMDR adaptive information processing model.
So it seems EMDR is not enough, then we have to do also stabilization.
Well, it is not, the EMDR is not enough. EMDR, any other trauma therapy will involve invoking the issues related to the trauma, and that will associate with anxiety, depression, dissociation, and other problems that we need to use as many tools according to the problem, of course. As we described, some tools are helpful with one particular problem, others are with the other. So we need to gear and adapt our approach to patients' needs. As we talk about using DIC with Muslim patients, because that's something which will make, in my opinion, DIC more effective with Muslim patients.
So, and final follow-up questions. Can we just use the stabilization? We didn't go to the full protocol of EMDR or client?
Well, I think it is very helpful. I mean, I know a lot of people are using this, particularly in places where there are no resources. Ideally, you have, within the adaptive information processing, you have to go through the processing of the whole. But if you have no resources to do that, and no personnel, qualified personnel to do it, then it is possible to use techniques of symptom reduction, like RDI and other techniques. Many other resources are being used really in the field on trials and to symptom reduction. But ideally, you really need the full processing of the traumatic, which only can happen through the EMDR, full sort of EMDR therapeutic intervention till the closure of the trauma. So,
Thank you.
It's mine. Yeah, okay. Could you move back to your slide, please? Title with methods in stabilization.
which one's ready?
Method in stabilization.
Methods?
Just move back.
Methods.
One more. Yeah, that one.
Methods, okay.
Methods one.
Sometimes,
And
yes.
these you mentioned about grounding, container.
Relaxation, mindfulness. I mean, of course, there are much more, as I said, that could be derived from other therapy. But I feel these are the things that worked and I have used and I'm more familiar with and I can talk about. That's why I listen to them particularly.
Yeah. My question is that
Yes.
which one is more effective?
Again, as I said earlier, it is the issue of what problems you are. I mean, grounding can be used with dissociation. And as I said, there are different levels of grounding, from simple technique like throwing a ball to the patient, asking to catch it, or to more sophisticated like Jim Knight's EMDR toolbox techniques that he used. So, which probably for level 1 is still not. That's why I didn't go into it. But I wanted to mention it so that people know that there are these techniques that can be used.
I would like to know in which phase of these 8 phases it is appropriate to work with client stabilization and when to use resources. Is it?
Yeah, I mean, I think it is part of the, as I said in the last slide, it is part of preparing patients. So phase 2 is usually the place where we teach clients these techniques. But of course, as you know, the patient doesn't come as textbooks. They can present with problems at different times. And if, for example, dissociation wasn't a problem when you assessed the patient initially and came later, then you might need to start introducing grounding at a later stage. But ideally, if you have assessed the patient and have a good idea about the problem they present with, then the preparation stage, phase 2, is the place where you teach these skills.
And also, what is timing needed for prepared patients? As you asked, you were asked about complex and simple trauma.
Well, that again,
is time depends on something?
it depends on the complexity of the problems and the spectrum of problems people are presenting with. I mean, in complex trauma, you might need 3-4 sessions at times to do the preparation. It's a full preparation. While in probably simpler PTSD, you might need just 1 session or even part of a session to do it. So it really depends on the problem and the presentation.